As we all know, the outcomes of rotator cuff repair has been improved by recent advances in surgical technique and instruments, including arthroscopy. Nevertheless, the reported treatment failure rates is approximately 40% for massive rotator cuff tears encompassing greater than 5%, 5 centimeters tear or tears involving two or more tendons. Literature has supported that up to 30% of the total rotator cuff tears can be classified as irreparable due to the massive tear size and severe muscle atrophy. So why do we have tears? The causes of high tear rate is probably multifactorial in nature and many be attributed to the older age of the patients, quality of the tissue, chronicity and tear size, muscle atrophy, fatty infiltration, bone mineral density, and repair technique in selected cases. There's always a debate between a single row repair versus double row repair. In selected patients, mechanical and biological enhancement of the tendon bone interface is therefore crucial to a successful outcome after rotator cuff repair surgery. We have demonstrated in our study the predictors of surgery after at 1 year, showing that bad outcomes associated with BMI, age, quality of tendon, and good outcomes having good quality tendon and lower BMIs. So how can we get better outcomes? Our outcomes have improved over the past decade, and treatment strategies have evolved considerably. Poor biological healing is still a problem, with failure of tendon bone fixation occurring in up to 26% of the small to medium tears and up to 94% in larger and massive tears. Better outcomes can be achieved by understanding the pathoanatomy of the cuff tear, by knowing the biological healing process, by improving and optimizing the bone to tendon fixation, and enhancing patient-specific customized rehabilitation. So what are the options do we have in our armamentarium? A number of synthetic and natural biomaterials have been developed into scaffolds. Those derived from extracellular matrices are thought to provide an ideal chemical and structural milieu upon which tissue integration can occur. Alternatively, synthetic scaffolds are predominantly used for their mechanical stability, although more recently their function has been enhanced by addition of several growth factors. Several constructs have emerged over the years, but due to concerns over adverse host reaction, poor integration, and high re-tear rates, none have been implemented into clinical practice. The ideal material should be able to meet the physiological demands of the native tendon while providing an environment that promotes host cell-mediated healing and regeneration of a functional enthesis. In addition to mechanical and biological constructs, there are tissue and PLLA spacers recently used, mostly known as the SCR procedure and the in-space device. Final resort is the reverse shoulder arthroplasty. As we all know, we will limit our talk to mechanical and biological advancements. So what is my repair strategy? My repair strategy involves a diagnostic arthroscopy, assessing the tendon tear, the type of the tear, the quality of the tissue, and then quickly trying to assess how I'm going to repair this. I usually use suture anchors with a double row technique with fiber tapes, and augment this with a tissue scaffold, either usually a dermal allograft. In cases where it is a redo surgery or re-tears, I tend to go with the marrow stimulation or bone marrow aspiration along with growth factors, or an amniotic membrane patch. Mechanical graft augmentations can be achieved with a number of synthetic and natural biomaterials. Xenografts like porcine dermal collagen, small intestinal mucosal, all have shown to have unfavorable outcomes and is not in clinical practice at the moment. Allogenic matrices are produced by decellularization of cadaveric materials from humans and are capable of bridging soft tissue defects while reducing the risk of graft rejection. Acellular dermal matrices are promising, and multiple studies by Bond et al. And Barber et al. Have shown that they had superior functional outcomes and increased constant scores in 2 years. A similar study was also conducted in 24 patients by Gupta et al. Showed better results. The future is still evolving with synthetic grafts, as there are significant immunogenic considerations due to xeno and allografts. PLA, GA, and PLLA and PDO have emerged as normal biomaterials for synthetic grafts. A PGA construct was shown to regenerate the enthesis and increase the type 3 collagen during the healing process. Moffat also conducted an in vitro study with well-aligned and unaligned electrospun degradable PLAGA based nanofiber scaffolds and showed excellent results which were matching that of the native tissue. Autografts still remain viable options, and multiple studies have shown facial autografts by Dr. Mahata for superior capsular reconstruction with good results. ITB can also be used, and biceps tendon can also be used to cover the defect, but there is still an added surgical time to obtain the autographs, so we still have to look for better options. A quick synopsis of the evidence of multiple scaffolds used for augmenting rotator cuffs have been shown. Most of the allogenic grafts have poor results, whereas the synthetic and acellular dermal matrix seems to be the way to the future. In the last few years, biological augmentation, especially for larger tears, have attained significant importance, as we have pretty much optimized the mechanical construct in terms of the surgical fixation. Therefore, various options have emerged now with marrow stimulation, PRPs, stem cells, extracellular matrix, along with the biologics, amniotic fluid and amniotic membrane, multiple growth factors, including MMP inhibitors, VEGF, and even exosomes. To understand the healing process of biological augmentation, we need to understand the tendon tear molecular pathogenesis. Tendon is a dense connective tissue with only a few cells, and a large number of closely packed and ordered collagen fibers, typically type 1 collagen fiber. It also contains a few amount of elastin, proteoglycans, and other connective tissue proteins. The main cell is a tenocyte, which is responsible for the production of tendon matrix proteins and matrix degradation enzymes. MMP1, 8, and 13 are important factors that can degrade all subtypes of collagen, and TIMP1 has been demonstrated to contribute to early human tendon healing process. The dynamic regulatory process between the MMP and the TIMP is known to maintain the healing and the degradation rate in the molecular level. The strategy to achieve a successful biologically augmented repair of a rotator cuff depends on multiple factors. The proper growth factor and a combination of growth factor with adequate blood supply is critical. The cells at the host site has to respond to the growth factor signaling process, and the delivery method or the carrier to provide the signaling at the optimal time during the healing cascade is paramount. This chart summarizes the PRP use in clinical practice on various studies, including case control studies and randomized control studies. Most studies have shown no difference in the late outcomes with PRP on both the clinical and in the radiological findings. However, Randelli et al. Showed a clinical improvement with PRP at 3 months. This video demonstrates an extracellular matrix being docked through the lateral portal into a well-prepared greater tuberosity bed for a rotator cuff repair augmentation. This is a video of a BMAC aspiration where you can see the Jamshedi needle being introduced into the greater tuberosity, and 30 cc's of concentrated bone marrow was aspirated, which was then spun over and concentrated and introduced into the healing. Anecdotally, the literature for BMAC seems to be much more supportive than PRP, and multiple studies done by Hernigo, Joe et al. And Tanguchi showed significantly lower re-tear rates compared to the controls, as well as the 10 years follow-up by Hernigo showed a positive correlation between the bone marrow mesenchymal stem cell transferred and the tendon healing at 10 years. This video demonstrates the introduction of a 3 by 6 centimeter amniotic patch membrane, which was rolled over and placed onto a large tear rotator cuff repair. I've noted that it's much easier to perform this with dry scoping to prevent the exodus of the graft material. The future of rotator cuff repair is very exciting, as new light has been shed on exosomes and cell-free stem cell derived extracts. The miRNA and the proteins in exosomes have shown to have significant impact on tendon cell healing. Lan et al. In the lab demonstrated that the M2 macrophage derived exosomes can repair rotator cuff. The significant advantage in exosomes is that it will not trigger an immune rejection or ectopic osteogenesis like cells, and have a higher level of safety and efficacy. Recently, we have demonstrated in the lab that these exosomes can be extracted without cells with a high level of efficacy. So my tips to achieve a successful outcome for a rotator cuff repair in 2022 will be to perform an arthroscopic repair with good footprint approximation, use suture tapes for poor quality tissue, and augment the repair with an extracellular matrix in larger tears, use biologics in the terms of bone marrow aspiration, concentrate in patients with high risk and poor quality, and to keep the rehab slow in massive tears. Kind regards, and thank you for your kind attention.